Thank you for joining me on Collaboration's Way of RAM's Living Rare Estate. My name is Caroline Mathie, and today I will be sharing with you some of the insights that we have obtained from our survey on adults living with rare diseases. This is a significant study that was conducted in 2019 to 2020 in the US amongst almost 700 patients and carers, and it represents more than 180 rare diseases. This unique database has given us an understanding of the patient perspective across a wide range of rare and ultra-rare diseases, from Ehlers-Danlos syndrome and narcolepsy to lupus and sickle cell disease, as well as a host of other diseases not represented on this chart. 70% of our patients were over the age of 30 years of age, and half of them had first experienced symptoms in childhood. We know that the average time for a non-oncological rare disease patient to get diagnosed is 7 to 8 years. And this indeed was true in our sample, where 75% had waited many years, seen many specialists before they actually got a correct diagnosis. A minority of the patients in our sample had a fatal disease, but for the others, they had to live with the knowledge of the severity of their condition, often the fact that it was a progressive disease and could become fatal in the years to come. As you might expect, when you're looking at 180 different rare diseases and so many patients, there were a plethora of symptoms reported to us. What I'd like you to take away from this chart is the wide range of those symptoms, from fatigue and sleep disturbance being very common across them all, almost 80% of patients, to pain, chronic pain from a variety of conditions that were experienced by many patients, joint issues, muscle spasms, skin, spine issues, cognitive impairment, to hearing issues and blood and bleeding problems. The wide range of symptoms, the number of organs affected, contribute to the delay in diagnosis. The physicians do not join the dots between the various symptoms that are reported to them, and this causes the patient frustration in their diagnostic journey. All of these symptoms, whether they're physical or mental, have an impact on patients' lives. This chart shows 4 aspects on which the patients were asked to use a 7-point scale to rate the impact on their rare disease. You can see that quality of life is affected, their ability to undertake the activities of daily living is affected, as is their mental health. You can also see that mobility is affected, and this is a theme that we'll come back to in ensuing charts in this presentation. Physical differences and actual physical abnormalities are very common, and more than half of the patients reported that these abnormalities are very bothersome to them. You can see on the right-hand side of this scale, we've got 30% of our sample saying that such disabilities, such differences are causing them problems. There is ongoing concern amongst rare disease patients about the level of knowledge and understanding of HCPs about rare diseases. It's not uncommon for the patients to claim, and to be correct, that they actually know more about their rare disease than many healthcare practitioners. You can see here on this list that we go from the family practitioner, who is not perceived to be very knowledgeable, perhaps not surprisingly, down to physicians who are perceived to be knowledgeable, such as the neurologist, the cardiologist, and the neuromuscular physician. With this lack of knowledge, lack of understanding of the patient, perhaps not surprising to find out that pain management is an issue for our rare disease patients. 62% of our sample reported that their pain management was less than effective. And indeed, anecdotally, we are hearing from patients that sometimes if they are acquiring opioids, they are considered to be addicts when they go for repeat prescriptions, and they're perceived with a stigma over them by the healthcare profession. These physical, mental and emotional issues experienced by our rare disease patients mean that fewer than half of them are currently in some form of employment. Many are unable to work and receive Social Security disability payments. Some don't receive disability payments at all, adding to their financial hardship. Of those who are employed, 4 out of 5 report to us that it has affected their ability to earn an income. Returning to the issue of mobility, 1 in 4 of our patients has a mobility issue. It may be that they can move without any sort of assistance, but still have some difficulty. It may be that they have to use a cane or a wheelchair or a walker. This impact on their ability to move around affects their ability to travel, whether that travel be local for domestic issues, going to work, going to school, doing the shopping. It may cause them to need to use a taxi, which has a financial impact on them, and it may preclude them from using public transport. Many of the patients are unable to work. It's not surprising, therefore, that in the US, their health insurance is affected as a result. Nearly all had some form of health insurance, but because it perhaps was not optimal, it did limit the amount of care and the type of care that they could receive. Indeed, about a quarter of the patients reported that out-of-pocket expenses had an impact on the care and medication to which they had access. A large minority of patients had to seek public benefits in terms of food stamps or home energy assistance. With rare diseases being so rare, the specialists that treat them are also rare and therefore geographically dispersed. 80% of rare diseases have a genetic component, and therefore many of our patients have had to travel to see a genetic counsellor, a journey which often takes 3 hours each way. As you can see, this means that the patient is not only having to make a financial investment, but a time investment. When they find the appropriate secondary care specialist, we hear about an average of 1 to 1.5 hours of travel, or 2 to 2.5 hours if they need ultra specialist care from a neuromuscular physician. When we asked our rare disease patients what they wanted to see improved in the future, there was a surprising degree of consensus. They wanted to see more education and training amongst the healthcare professionals, and a third of them reported that they wanted to be treated with more respect and compassion by the medical community. In line with what we've seen, the financial burden on the patients is such that it's affecting their care, and they were asking for better financial and insurance support to enable their management of the condition. When we asked our patients what they would like to see in the future, we saw that more than a third wanted to see physicians have better education and training in rare diseases. A further third simply wanted to be treated with more respect and compassion by the medical community. That's a third of nearly 700 patients. We've also heard about the financial burden on the patient and its impact on their care and their support, and these were areas that, not surprisingly, patients wanted to see improved. So in order to sum up, the patient journey, the odyssey, is still significant and fraught with frustration whilst the symptoms remain untreated. Healthcare professionals are perceived to be uneducated, lack understanding about rare diseases, and fail to treat patients with respect. The burden of disease prevents many patients from having employment, and this in turn limits their access to medical insurance. Patients experience societal, cultural, and financial changes in accessing the care that they need, and consequently, many rare disease patients fail to get timely access to the care and the medications that they need. I would like to thank the World EPA Congress for hosting the first community-based stakeholder collaboration, and I'd like to thank you all for joining us today. See you all at the Living Rare after party later on.